TPN Fundamentals, Part 4, Monitoring TPNs. We've come to the final part of our TPN lecture, where Andre and Pierre will take us through some key monitoring concepts and TPN controversies. Let's talk about the daily routine monitoring of a patient who's on TPN. The daily assessment of a TPN patient should include a review of pertinent laboratory data, that is serum electrolytes and CBC, daily weights to identify whether there is weight gain or weight loss, fluid balance, the input outputs, urine output, and NG output, fingerstick blood sugar and sliding scale insulin use, and acid-base status, and ABGs if the patient is on a ventilator. There should be 5 questions to ask on a daily basis when managing a patient on TPN. Question number 1. Is the patient receiving adequate calories and protein based on their requirements? If not, increase the TPN rate or increase the macronutrient concentrations. Question 2. Can the patient be fed enterally or orally? Is the gut working now? Identify the duration of the TPN and transition to enteral or oral diet if possible. Does the patient have electrolyte abnormalities? Correct them by supplementation or removal reduction from the TPN. Limit increasing the electrolytes in the bag by no more than 50% unless you have a very good reason to. Is the patient experiencing hyperglycemia? If so, add insulin to the TPN and or reduce the dextrose load if possible for better glycemic control. Is the patient accumulating fluid? Are the INOs positive? Is there weight gain and edema or decreasing sodium and albumin levels? A daily weight increase of greater than 0.25 kilograms generally reflects fluid gain rather than the increase of lean body mass. Reduce the fluid rate, concentrate TPN to get the same ingredients, and possibly add diuretics. So let's review the 5 questions to ask. Is the patient receiving adequate calories and protein? Can the patient be fed enterally or orally? Does the patient have electrolyte abnormalities? And is the patient experiencing hyperglycemia or are they accumulating fluid? Here's a question that is often asked. Is albumin or prealbumin useful biomarkers for nutrition? Multiple studies have shown that these parameters are unreliable surrogates of nutrition status, and they are often decreased because of inflammation, infection, or fluid overload. Another question that's often asked is, how do I replenish phosphate IV? This can easily be done by following the table below. For a phosphorus level between 2.3 and 2.7, we give 0.1 millimole per kilogram of IV phosphate. A level of 1.5 to 2.2, we would give 0.25 millimoles per kilogram of phosphate, and a phosphorus level less than 1.5, we will give 0.5 millimoles per kilogram of phosphate. The recommended rate is 5 millimoles per hour, and this can be given either as potassium phosphate or sodium phosphate. And remember that every 3 millimoles of potassium phosphate contains 4.4 MEQs of potassium. The following recommendations are empiric because serum phosphorus concentrations may not accurately reflect total body stores. For renally impaired patients, consider reducing the dose by 50% or less. Let's talk a little bit about the refeeding syndrome. What is the refeeding syndrome? The refeeding syndrome refers to the clinical signs and symptoms resulting from rapid initiation of feeding in patients with pre-existing malnutrition. So in chronic malnutrition, these patients have a decrease in insulin and decreased use of glucose, and a reliance on fat for energy, which results in depletion of intracellular potassium, phosphate, and magnesium. Upon refeeding with hypertonic dextrose, these patients see an increase in insulin, a shift to carbohydrate metabolism, cellular uptake of electrolytes, and an increased need for coenzymes. Carbohydrate calories converting to dextrose triggers the secretion of insulin, hyperinsulinemia can lead to decreased serum levels of potassium, phosphate, and magnesium due to shift of electrolytes from the extracellular space into the cells. Vitamin deficiencies may occur due to depleted vitamin stores and increased roles for biochemical function. Thiamine is a cofactor for glucose metabolism and should be administered to the patient at a dose of 100 milligrams daily for 3 to 5 days. The avoidance of overfeeding and excess carbohydrate is the first step in blunting the initial insulin response, applying the concept of permissive underfeeding. Attention to the refeeding syndrome is especially important for the patient with risk factors such as alcoholism, weight loss, low body mass index or BMI, and prolonged periods of NPO. Specialized nutrition support should be initiated and advanced slowly for these at-risk patients. Close monitoring is needed to avoid serious electrolyte abnormalities and the cardiovascular effects. Overfeeding. Overfeeding a patient with too many calories can lead to hyperglycemia and fatty liver. Overfeeding is the administration of excess dextrose or fat calories. Overfeeding can induce a variety of metabolic complications during parenteral nutrition. So what happens when we overfeed a patient? Excess carbohydrates result in hyperinsulinemia, which stimulates lipogenesis and inhibits beta oxidation of fatty acids. Carbohydrates are converted to fat, which is stored in the liver. That leads to steatosis or fatty liver disease. On the other side, excess lipid contributes to parenteral nutrition-associated liver disease, where excess calories contributes to the development of both steatosis and cholestasis, leading to steatosis or fatty liver disease. Hepatic dysfunction is a common cause of morbidity and mortality in patients receiving long-term parenteral nutrition. Liver abnormalities such as gallstones, biliary sludge, or cholestasis can arise. Here's how we calculate osmolarity. Remember that phlebitis can occur if the TPN solution's osmolarity is too high for a peripheral vein. Use the table below to calculate the TPN's osmolarity. We take the total grams of dextrose per liter and multiply that by a factor of 5. Add that to the total grams of amino acid per liter multiplied by a factor of 10, and then add that to the total number of MEQs per liter of all electrolytes multiplied by 2 to get the total milliosmoles per liter. Here's an example of calculating the osmolarity of a standard peripheral TPN, dextrose 8%, amino acid 3%, fat 3%. The total milliosmoles per liter of this solution is 877, which is below the limit of 900. Why do TPNs require filters? Here's some background. Calcium and phosphate have limited solubility in TPN solutions. Serious adverse effects have been reported, including deaths due to calcium phosphate precipitates causing pulmonary microvascular emboli. With 3-in-1 formulations, one cannot visually see this precipitation. Therefore, the FDA issued a recommendation for the routine use of a 1.2 micrometer inline filter for all 3-in-1 TPNs to help decrease the chance of fatal precipitants infusing into the patient. And here's a diagram of how the filter looks like. For 2-in-1 formulations, it is suggested that 0.22 micron filter be used, which has the advantage of also filtering out bacteria. A larger filter size is required for 3-in-1 solutions to allow the lipid globules from the fat emulsion to be infused into the patient. Let's spend a few minutes talking about some concepts and controversies surrounding TPN. What's a trophic feed? Trophic feeding is usually defined as 10 to 20 mLs per hour or 10 to 20 calories per hour of enteral feedings, up to 500 calories per day. Why use a trophic feed? Trophic feeds prevent mucosal atrophy and maintains gut integrity, even if enteral feeds cannot be administered at high rates. Studies in animals and humans have shown a trophic effect of enteral nutrients on the integrity of the gut mucosa. Even small volumes of enteral nutrition can be beneficial to the gut microbiome by preserving intestinal epithelium, mucosa, tight junctions, and microvilli height, thus preventing bacterial translocation. The overall benefits of trophic feeding are related to better GI tolerability associated with a lower risk of bronchoaspiration and refeeding syndrome, and lower insulin requirements and better glycemic control. It is sufficient to maintain gut functionality and integrity, thereby reducing morbidity and mortality among critically ill patients. The disadvantage is that trophic feedings will be insufficient to deliver the usual energy and protein requirements that's desired for high-risk patients. So does the use of trophic feeds lead to negative patient outcomes? This was studied in the Eden trial, which was published in JAMA in February of 2012. This study compared the initial trophic feedings versus full enteral feedings in patients with acute lung injury. This was a prospective randomized controlled trial of 1,000 patients requiring mechanical ventilation. The 1,000 patients were divided into two groups. The first group received trophic enteral feedings at 20 mL per hour, or 25% of their calculated goals, for 6 days. There were 508 patients in this group. The other group received full enteral feedings to 80% of their calculated goals for 6 days. The number of patients in this group was 492. The results of this study showed that there were no significant differences in 60-day mortality and ventilator-free days between the two groups. Patients in the full feeding group had significantly more regurgitation, fluid gain, and use of antidiarrheal agents, and had a higher mean plasma glucose and average hourly insulin administration. In conclusion, in critically ill patients, permissive underfeeding using trophic amounts of enteral feedings for 6 days is safe and effective to use compared to full feeding, and may have potential benefits in reducing adverse GI effects. There were no between-group differences in acute or long-term functional outcomes. Let's move on and talk about delivering nutrition in acute pancreatitis. Acute pancreatitis is the single most common GI diagnosis in hospitalized patients. It's the 5th leading cause of hospital deaths. Acute pancreatitis is a potentially fatal condition, often associated with nausea or vomiting and abdominal pain with or without eating. Acute pancreatitis ranges from mild inflammation to severe pancreatic necrosis. The most common cause of acute pancreatitis is cholelithiasis, leading to a backup of bile into the pancreas. Bile acids increase calcium concentrations and activate inflammatory mediators, causing pancreatic damage due to digestive enzymes auto-digesting the pancreas. In the figure, you can see the pancreas and the duodenum, and a gallstone that blocks the common bile duct where the pancreas duct joins. Obesity increases the incidence of acute pancreatitis due to gallstone formation. The second most common cause of acute pancreatitis is alcohol misuse. Alcohol exerts direct localized toxic effects on the pancreatic cells, leading to inflammation. Smoking has been shown to accelerate the progression of alcoholic pancreatitis. Initial treatment for acute pancreatitis involves early fluid resuscitation, oxygen, and adequate analgesia. Prophylactic antibiotics should only be administered to patients with greater than 30% of pancreatic necrosis, where there is a higher rate of infection. In the past, traditional management of acute pancreatitis did not include nutrition therapy and promoted time to allow the pancreas to rest. Some thought that using enteral feeding would stimulate the exocrine function of the pancreas, leading to negative effects. On the contrary, starvation alters the gut's microbiome, leading to loss of gut barrier function. The immune function and permeability of the gut mucosa becomes destroyed, leading to bacterial translocation. The gut mucosal barrier is breached, and pancreatic digestive enzymes escape through the intestinal wall and into the systemic circulation. Providing enteral nutrition offers the major benefit of an immunologic effect on the gut microbiome, including maintenance of normal intestinal motility, IgA production, prevention of bacterial overgrowth, and decreased bacterial translocation and intestinal permeability. In mild pancreatitis, oral feeding can be started if there is no nausea or vomiting and abdominal pain has improved or resolved. There was no difference between the use of a clear liquid diet or a low-fat solid diet. In mild disease, providing an on-demand oral diet, not limited to clear liquids, is safe. In moderate to severe cases of pancreatitis, nasogastric tube feeding appears safe and effective and is the preferred route to deliver nutrition because it encourages the rapid return of normal gut function. Enteral nutrition is feasible, safe, and beneficial in all types of pancreatitis. Parenteral nutrition. TPN was once recommended for patients with severe pancreatitis, but it is now associated with increased complications, infections, mortality, and length of stay compared to enteral nutrition. Based on expert consensus, in patients with severe acute pancreatitis, enteral nutrition should be provided over parenteral nutrition because of favorable clinical outcomes. Studies demonstrate an association between enteral nutrition and decreased rates of mortality, infectious complications, organ failure, and surgical interventions. The use of TPN should be considered only in high-risk critical illness when delivery of enteral nutrition is not an option after 1 week from the onset of the pancreatitis episode. Liver disease. The prevalence of malnutrition in patients with liver disease increases with severity. It can be as high as 60 to 95% in those with Child-Pugh Class C severe cirrhosis. In patients with acute or chronic liver disease, the preferred route of providing nutrition is enterally. Enteral nutrition has been associated with decreased infection rates and fewer metabolic complications in liver disease and after liver transplant when compared to TPN. There are several key points to consider when formulating TPNs for liver disease patients. The first key point is that protein requirements for the patient with hepatic failure should be determined in the same manner as for general ICU patients, about 1.2 to 1.5 grams per kilo per day. In patients with ascites, or if the patient is fluid expanded, use the estimated dry or ideal body weight for the energy calculation. Use actual body weight in those patients without ascites. Protein should not be restricted as a management strategy to reduce the risk of developing hepatic encephalopathy. Key point number 2. For severe refractory hepatic encephalopathy, the amount of protein may need to be limited. However, prolonged protein restriction is not recommended. Historically, protein restriction was used to help reduce the risk from hepatic encephalopathy, but such a strategy may worsen nutritional status and decrease lean muscle mass. So provide the protein at 0.6 to 0.8 grams per kilo per day for 3 days and increase to 1.2 gram per kilo per day. Reduce the amount if the mental status deteriorates. Key point number 3. Standard nutritional formulation should be used in ICU patients with acute and chronic liver disease. The use of branched-chain amino acid-enriched solutions such as hepatamine remain controversial, as studies show a beneficial effect on mentation and encephalopathy, but no effect on quality of life or mortality. Branched-chain amino acid formulation should be reserved for the rare encephalopathic patient who is refractory to standard treatment with luminal-acting antibiotics and lactulose. And finally, key point number 4, patients with cirrhosis are prone to developing deficiencies of water-soluble vitamins, mainly group B, fat-soluble vitamins, and zinc and selenium. In summary, we reviewed the daily monitoring considerations for a patient receiving TPN, including recognizing the refeeding syndrome. And we discussed the controversies such as trophic enteral feedings and TPN use in pancreatitis and in liver disease. We've got a lot in store at the PharmEasy Tutor channel. There will be upcoming talks on cold blue emergencies, management of acute heart failure, electrolyte management, quinolone side effects, and hospital pharmacy, and much, much more. So please stay tuned to us. Thanks for tuning in to watch this installment of the PharmEasy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.